Before we begin the webinar, I'd just like to go over a few housekeeping items. Participant phone lines are muted. This webinar is being recorded. If you have any questions for our speaker during the presentation, please enter them into the question box on your control panel for the webinar on the right-hand side of your screen, and Jill will answer them at the end of the presentation. Everyone will receive a copy of the PowerPoint slides, a link to complete the evaluation, and a link to the recording of the webinar by the end of business day. Mrs. Jill B. Rourke, MPH, began her career in public health in 1997 as a pediatric diabetes educator. Jill then worked in the clinic at Planned Parenthood of North Central Florida, where she provided case management for abnormal PAP follow-up and managed the colonoscopy clinic. She then moved to Georgia, where she began working at the Emory University School of Medicine, first with a federal-level training program for public health clinicians, and then at the Emory Vaccine Center coordinating immunization research activities for HIV vaccine clinical trials. Jill began working at the CDC in 2004, providing communication, consultation, and project management, first in the CDC Office of the Director and then for the National Center for Health Marketing. Currently, Jill leads the Adolescent Immunization Communication Team in the CDC's National Center for Immunization and Respiratory Diseases, focusing on HPV vaccine communication science for parents and clinicians. Please join me in welcoming Jill Rourke. Jill, I'm going to switch it over to you now.
Hi everyone, hopefully you can hear me okay. Looks like everyone should be able to hear me. And I do want to make sure that you can see my slides correctly. And I'm just going to check on that. Sarah, can you see my slides okay? All right. So hi everyone, I am Jill Rourke and I am the lead for Adolescent Immunization Communications at the Centers for Disease Control and Prevention and the National Center for Immunization and Respiratory Diseases. And yes, that is a mouthful and we're kind of used to it. So today I am going to talk with you primarily about HPV vaccination. And I have a couple of slides that you need to see here while I'm talking to you. I don't have any financial disclosures related to this presentation at all. We may be discussing some things that aren't approved by the FDA, but they are in accordance with the ACIP recommendations. I think you may know that many of the ACIP recommendations may not exactly match the indications from the FDA, but they are recognized and recommended by the ACIP. I have 4 objectives today. We're going to talk about HPV vaccination for the importance of cancer prevention and why we vaccinate 11 or 12, as well as listing the recommendations for HPV vaccine for both girls and boys. I'm going to give you some hopefully useful and compelling information about HPV vaccine to help parents make the decision to vaccinate their children and accept the recommendation you give them, and then also help you find the resources that are relevant to your immunization practice. So we're going to start with HPV disease, and often a question that folks ask is, well, really how many people are being affected by HPV in this country? And we're going to start actually not with cancers, but with HPV disease. And as you know, there's many, many types of human papillomavirus. The types that we are primarily discussing today are the mucosal sites of infection. We have both high-risk and low-risk HPV. High risk is oncogenic. The most common is HPV-16. HPV-18 is the second most common type, not nearly as virulent or as common to cause cancer as HPV-16, however, but it can cause a number of different cancers, including cervical, anogenital, oropharyngeal cancer, as well as dysplasia or cervical precancer. And cancer of the cervix is the only cancer of the HPV cancers that actually has a precancerous stage. Unfortunately, oropharyngeal cancer does not, which makes it really difficult and why there's not an indication. We'll talk a little bit more about that in a bit. We also have the low-risk types, which are 6 and 11. While they're not cancer-causing, they do cause genital warts as well as laryngeal papillomas or recurrent respiratory papillomatosis. And they also can cause low-grade cervical disease, so usually CIN1, precancerous lesions of the cervix that will not continue to progress, but those can be caused by 6 and 11. So almost everyone is going to get an HPV infection in their lifetime. It's pretty difficult to be a human and not get any kind of HPV, much less a mucosal form of HPV. Nearly 80 million Americans are currently infected. We see about 14 million new infections each year. Most of these are happening in teens and young adults because HPV infection usually occurs very soon after sexual debut. Most people have no idea that they've ever been infected if they don't have any signs or symptoms of it. Women usually find out they've been infected because they have an abnormal Pap test with a positive HPV test or a diagnosis of genital warts. Men usually only find out they've been infected because of a genital warts diagnosis as well, or unless they develop an HPV positive oropharyngeal cancer. About every year in the United States, 27,000 people
Jill,
are diagnosed.
sorry to interrupt, but it's not the correct slide that is showing right now. We're stuck on, it looks like everyone can only see the continuing education slide.
Okay, let me figure out why this is happening because I'm seeing them. Let's try. Is that better?
Yes.
Did it just hop? I'm so sorry. I'm not quite sure why it did that, but
that's okay. Thank you so much. Sorry for interrupting.
My apologies. Luckily, you will have all the slides, and I really pretty much just read what was on the slides. So,
okay.
All right, so back to the slide. So about 27,000 people are diagnosed with the cancer each year in the United States that has been caused by an HPV infection. And that doesn't sound like a lot, 27,000, but that's one case every 20 minutes, which when parents say, you know, that just doesn't seem like a lot, that's one person every 20 minutes, and that can help it put it in perspective for them because numbers like 27,000 can be difficult to understand when we don't put them into context, especially for parents. We talk about the new cancers that are caused by HPV each year. We look at an average of cancers, the numbers from, say, 2006 to 2010, so the average number of those cancers over a period of years. There's going to be new cancer data that comes out. We'll actually be updating these slides in July. In the MMWR, there'll be an update to the current cancer statistics of cancers caused by HPV and some new definitions as well. But as you can see from the slides here, in women, the most common cancer is cervical cancer, and the most common cancer in men is oropharyngeal cancer. Now, as I said, these are averages over a number of years, and you can see that we're always a few years behind. Some of the private researchers are actually saying that their oropharyngeal cancers are much higher and have probably already eclipsed cervical cancer in terms of the number of cancers caused by HPV. And a lot of folks think about HPV cancers as being sort of an older person's disease, and we often hear from clinicians that they're really surprised to hear that one of their former patients who maybe is now about to start a family has developed invasive cervical cancer, and that can be really surprising. And so let's take a look at the age of diagnosis for various cancers. So for women, we can see that that top blue line there, cancer, the average, or the median age rather, is 48. And yet we see that about 1 in 8 women who develop cervical cancer are actually very young, very much in the time of their childbearing years. If you have not yet seen it, I highly encourage you to watch the Someone You Love, the HPV epidemic movie. You can actually get continuing education credit for it from the Indiana Immunization Coalition. And it's a really great story of 5 women who were all young women who were either diagnosed with HPV disease or cancer, and it's a really fantastic story. And one of those is actually Kristen. It's a picture of Kristen and her dad. And Kristen unfortunately died 11 months after her diagnosis. She was diagnosed at age 23 with cervical cancer. And it's a really good reminder to us that, you know, these cases aren't just cases, they're real people, and some of them much younger than we would ever imagine. So it really highlights the need for HPV vaccination, which is primary prevention. I mean, it's wonderful that we have a good cervical cancer screening rate in the United States, but that is not primary prevention. And sometimes by the time we catch cervical cancer, it's too far gone to save a woman's, usually at least her ability to bear children, if not her life. And if you don't have a chance to watch the movie, there's a short book that was written by her father that actually details the progression from the time that they discovered something was wrong to her diagnosis and then her chemotherapy and eventually her passing. But it's a great book. You can buy it on Amazon. So not only are we preventing HPV cancers in female patients, but we're also preventing invasive testing and treatment. And like I said before, you know, the numbers around cervical cancer aren't huge, especially because we've done such a good job. In fact, the cervical cancer rates in this country have come down tremendously in the last 50 years with Pap testing. It used to be the #1 of all the women's cancers, and now it's the most preventable of all the female cancers, and so we've done a great job with that. However, we still see a number of states, including Illinois, that have relatively high cervical cancer rates and relatively low vaccination rates. And so this sets up worsening health disparities for cervical cancer, especially geographically. And as I mentioned before, there's about somewhere between 10 to 11,000 cases per year of cervical cancer and about 4,000 deaths in women, cancer caused by HPV, cervical cancer caused by HPV. And I actually, sorry, my slides are out of order. I apologize for this. But as I said before, we do know that cervical cancer was one of the most common cancers in women. Around the world, we actually see many more cases because they don't have the cervical cancer screening that we have in the U.S. Now, there's a big disparity among women in terms of cervical cancer, and we see that Hispanic women have much higher rates of cervical cancer, and Black women have very high rates of cervical cancer, but are more likely to die from cervical cancer than other races and ethnicities. Now, again, 10,000 and 4,000 doesn't sound like a whole lot until we start talking about cervical precancer in U.S. females. So for women who have the Pap test and maybe also an HPV test if they're old enough to have co-testing, if there is abnormalities, they are going to go on and have additional testing. They're going to have a colposcopy, which is looking to evaluate what the lesion is, possibly taking biopsies, and we have about 2 million women a year that have to have some level of colposcopy with number of biopsies. From those biopsies, there are about 1.4 million new cases of low-grade cervical dysplasia diagnosed in the United States every year. And then there's about 330,000 new cases of high-grade cervical dysplasia. There's high-grade cervical dysplasia. They go on to having either a LEEP, which is a looped electrical excision process, or a cone biopsy. In the picture here, that is a cold knife cone biopsy. You can see the cone shape being taken from the cervix on the left, takes part of the endocervical canal as well. And unfortunately, when this happens, it does put women at risk for additional complications, including pregnancy complications. And so the cervix becomes unstable at that point, difficult to carry a pregnancy to term, which can lead to extreme preterm delivery, preterm birth weight. So we know that there can be consequences. And so while Pap testing is wonderful for catching cervical dysplasia and sometimes cervical cancer at a point when it can actually be treated, we can prevent most of this with HPV vaccination, and that is really exciting. So not only are we preventing devastating cancers caused by HPV infection in female patients, but also in male patients as well. So the cancer cases that are most likely caused by HPV, you can see here the bars, and of the purple sections, those are the ones that are actually attributable to HPV, and there's some differences in terms of HPV associated and HPV attributable, and it has to do with actually testing the sample for cancer or whether or not the sample was taken from an area that usually is an HPV cancer. But you can see there how high the rates of HPV cancers are for anal, penile, and oropharyngeal cancer in men. Now, oropharyngeal cancer has been getting a lot of press lately, and I'm going to show you the anatomy of the oropharynx, and so we can be very specific about what this area is. So essentially, it is the base of the tongue, the back of the throat, and the base of the tonsils. So a little bit different than the areas usually infected, or rather that get oral cancer. Now, why this is so important, even though there is not an indication for oropharyngeal cancer for HPV vaccine, we are seeing increasingly higher rates of HPV-related oropharyngeal cancer. In fact, it's increased by 225% in the past 30 years. And you know, one of the things that we know about this is we see less and less tobacco use, less HPV negative cancers, and more HPV positive cancers in men. And there's a difference in when they're presenting with the cancers, you know, and what's one of the problems is when you have someone who's not a heavy drinker or smoker, it is a lump in the throat that's being presented. Often HPV cancer isn't the first thing that a clinician thinks of. And so unfortunately, it's usually much further along when someone is diagnosed. In terms of age, the median age for an HPV-associated cancer for men for oropharyngeal cancer is age 58, although we're seeing more and more younger men, often you know, high SES, white men who have not been heavy smokers or drinkers. So I expect as we get the new cancer data, we're going to start to see these numbers change. We get asked all the time, why isn't there an indication for oropharyngeal cancer, and will we see that change at some point? And you know, one of the problems that we have in general with a cancer preventing vaccine is that there's a long period of time between when the infection occurs and then the cellular changes start to happen and when we actually see cancer present. And so because of that long latent period, it can be really difficult to prove efficacy in preventing oropharyngeal cancer. As I mentioned before, there's no precancerous state of oropharyngeal cancer, and so it can be really difficult. Also just really difficult to do even HPV testing of the oropharynx just because of the mucosal site and the way that the tissue is very difficult to get a good sample. Much as it can be difficult to get a good strep sample, even more difficult to get a good HPV sample from the oropharynx. So while we don't necessarily have efficacy data about prevention of oropharyngeal cancer with HPV vaccine, we do know that if we prevent the infection that causes these cancers, then we are most likely preventing the cancer. So we do expect that HPV vaccination will be effective for the prevention of HPV-related oropharyngeal cancers. Most HPV-positive oropharyngeal cancers are caused by HPV-16. That is currently in all of the HPV vaccines that are available in the United States. So we can expect that if we are preventing infection, so that if someone is vaccinated prior to exposure, then we're going to prevent that cancer in them. Now we've definitely had clinicians say to us time and time again that they're shocked, like, how do we have this vaccine that prevents cancers and parents aren't lined up to get it? Or, you know, if this was a vaccine against breast cancer, we'd have lines around the block. So let's talk a little bit about what we can do to remove some of these barriers for parents. And the barriers that I'm going to list here are all things that are from either the National Immunization Survey that we do on an annual basis with parents, or other data that we have collected through research here at CDC. So parents tell us things like, well, it's not needed, or we discern that there's a lack of knowledge about HPV disease and HPV vaccination. So we want to help those parents understand the HPV vaccine is needed for cancer prevention. For the parents who are concerned about safety and side effects, we can tell them about the extensive safety research that goes into it, although we have to make sure that that's really what those parents are talking about, that they're actually concerned about safety issues and finding out what their specific safety issues are. Some parents just want to know how well this works, and luckily we have a lot of data now on the impact of HPV vaccine, and I'll talk a little bit about that. There are parents who are still concerned that this is just permission for sexual activity, giving their kids a green light, but we've got lots and lots of data now to show that we actually don't see any increase in sexual activity with those kids who've been vaccinated. Some parents believe that 11 or 12 is just too young, and so we want them to understand why 11 and 12 is important. And then some parents cite the main reason for not getting their kids vaccinated is that they don't receive a recommendation. So we want to make sure that those parents are receiving a good, solid, effective recommendation for HPV vaccine. And in this case, it's a bundled recommendation is actually the most effective. And that's utilizing the adolescent platform to its fullest. So recommending all of the vaccines at the same time and in the same appointment. So if we look at the HPV rates, HPV vaccination rates in this country, we can look at what we actually have versus what's achievable. So for girls who are age 13, and we obviously want girls and boys to be vaccinated before they turn 13, the recommended ages are 11 and 12. For those born in the year 2000, the actual rate of initiation for HPV vaccination for girls was only 47%. If those girls had received HPV vaccine at the same time that they received any other vaccine, the rates could be as high as 91%. So what that tells us is we have lots of girls and boys going to see their clinician and they're receiving a vaccine, but they're not receiving HPV vaccine at the same time. And so we want to make sure that we get all of them. Our high HPV vaccination coverage is possible with the existing infrastructure and healthcare utilization in the United States, and we know that because of Tdap vaccination and how incredibly high our Tdap vaccination rates are. So that's a good way to look at whether or not you're doing a good job of getting your patients HPV vaccine, is to look at what your Tdap rates are and compare that with what your HPV vaccine initiation rates. So we've had clinicians tell us that they find it helpful to know how well HPV vaccination works and how long it should last. That's a common question that parents ask. And so we want to help parents understand that HPV vaccination is safe, it's effective, and it provides lasting protection. That the benefits of vaccination outweigh any potential risks, and that the safety studies show that it's as safe as meningococcal conjugate vaccine and Tdap vaccination. We want parents to understand that this vaccine works. We've got a lot of data showing that it prevents, we can see that it's preventing infection, we can see that it's preventing cervical changes, and this has been reported in a number of countries, including the US. And the HPV vaccine lasts. So often we'll hear a parent say, well, 11 or 12 is just too young. I want to protect her, when she's in college, so we'll wait to get the vaccine. But, HPV vaccine, we don't have anything to suggest that this protection is not going to be long-lasting. There's no evidence of waning protection. And part of that comes from just the technology of how HPV virus-like particles are designed, and it's the same vaccine technology that we have with hepatitis B vaccination. It also happens to use the same adjuvant, at least with the Merck vaccines, Gardasil and Gardasil 9. And so we know that hepatitis B vaccine confers lifelong protection, and we expect to see the same thing with HPV vaccine. In terms of impact, we've been looking at impact of HPV vaccine. It's been continuing to be monitored since the vaccines have been out. In the NHANES, which is the National Health and Nutrition Examination Survey, using data on HPV infection, we can actually see a large decline in the number of adolescents with HPV infections from before, which is the tan line, and after that introduction of the HPV vaccine program in the United States. And then, so that's the graph on the left. On the graph on the right, we actually look a couple years later. So HPV vaccine was started in 2007 in the US. Just 2 years later, we saw an even larger decline. So a 64% decline in 14 to 19-year-olds with HPV infections. And then, because by then we've had some older adolescents and young women being vaccinated, we've seen a 44% decline in HPV infections in the next older age group, which is exactly what we expect to see. I've also had clinicians tell us that they're really surprised to learn that parents value HPV vaccine as much as the other adolescent vaccines, because on the surface it doesn't seem that way. Our Tdap rates are really high, our meningococcal rates are often very high, but the HPV vaccination rates haven't been. But it's really important, and I urge you not to anticipate opposition from parents, because we are learning more and more about how much parents truly value HPV vaccine. So there was a study done by Mary Healy in Texas, and she was actually studying a number of different things around immunization in general, and some of the data showed how parents felt about particular vaccines. And so on a 1 to 10 scale, parents gave their value of each of the following vaccines, and you can see that across the board for vaccines that adolescents might receive, that it was about the same, 9.2 to 9.5 on a 10-point scale. In the same study, Dr. Healy they inquired with physicians, how much do you think parents value the following vaccines? And for meningococcal vaccine, hepatitis, and pertussis vaccines, the providers estimated about the same as what the parents' actual value was, so they were guessing correctly. So almost exactly the same. But when it came to influenza and HPV vaccines and adolescent vaccines in general, you can see that there was a big difference. So the providers were guessing that parents did not value HPV vaccine as much. And so that's going to definitely affect the conversation that occurs in the exam room between you and the parent of the patient. So whether the concern is real or perceived from the parents, it's going to influence the way that you recommend and administer HPV vaccine. So we have clinicians that have said, I really thought I was making a strong recommendation, but my patients are leaving unvaccinated. I feel like I'm giving the same strong recommendation to all my patients, but my initiation rate's only at 45%. And so I want to talk a little bit about how to handle that and also helping you to not expect opposition from parents. So one of the things we found is that a lot of parents who were possibly hesitant about their babies receiving certain vaccines, those kids have grown up now and they're at the age of getting their adolescent vaccines, and the parents still have a lot of questions. But what seems to be a little bit different about HPV vaccine is that those questions aren't necessarily indicating hesitancy or a lack of confidence. They're really looking for reassurance and information from you, the clinician that these parents trust with the care of their child. And so with parents who seem to be sort of hesitant around HPV vaccination, it's really important to remain engaged with them and to verify that you are actually touching on the actual issues that they're truly concerned about. So a good example of this is we were doing a survey with parents about HPV vaccination and safety concerns. And it was amazing the things that parents listed as a safety concern, like efficacy or effectiveness and how long it'll last, duration of protection. So things that we wouldn't necessarily consider to be safety, but that's how parents were categorizing them. So we want to be sure that we're really getting the right question out of parents and verifying that we understand what their concern is. So also, this is another, this is sort of a funny slide, but it drives home a really good point, which is it's really easy to risk profile patients. In fact, I have a very close friend whose daughter is, just not as advanced as some of her peers, be very low in the teenager stages, and her mom was very concerned about going ahead and getting her vaccinated, and they're Catholic, and I knew what the concerns were, and she said, well, I just know that she's nowhere near being exposed yet. And it would be very easy for me to say, I know her too, and I think you're right, and I think you could wait a couple of years, but this is why we don't risk profile. When sweet little Sandy shows up to the doctor's office in the fall and she's still in her poodle skirt, the idea is that, probably not at risk for an HPV infection, but during that school year she meets Danny Zuko, and by the end of the school year he looks like, and she has probably already been exposed to HPV. So just in that 1 year, we can't predict whether or not someone is going to be at risk, especially knowing that most people are going to be exposed to HPV at some point, and that HPV infection occurs really soon after sexual debut, and we cannot predict when someone is going to become sexually active, especially if it's not their choice. So clinicians have told us that when they recommend HPV vaccine in the same way and on the same day as other vaccines, that parents are responding with acceptance, and we think that that's about 70%. So about 70% of the time, parents receive a bundled recommendation that bundles together all the adolescent vaccines, that they're going to accept the recommendation. So what our research shows is that the most effective recommendation you can give is one that groups all the adolescent vaccines. So recommending HPV vaccine the same way you recommend Tdap and meninge. And then also importantly on the same day. So recommending them together all on the same day and administering them all on the same day. So a little helpful visual here is there is your bundle of meningococcal, HPV, and Tdap vaccines, all the preteen vaccines. And I think this is an important visual even for parents to help them realize that HPV is just a normal part of adolescent immunization. So what that might sound like is, Mom, now that your daughter Sophia has turned 11 years old, she's due for 3 vaccines. These are vaccines that are going to help protect her from meningitis, the cancers caused by HPV, and also give her a booster for pertussis. My nurse is going to come back in and give those shots at the end of the visit today. So as a reminder, the recommendation for HPV vaccine is for 11 or 12 for routine vaccination. However, it can be started as early as age 9. I had some clinicians here in Georgia asking me if they should start recommending it sooner. They were in the habit of not recommending HPV vaccine until 12 or 13. They had a couple of 12-year-old patients who became pregnant, and they said, should we be recommending HPV vaccine sooner? Absolutely, there's nothing wrong with recommending it before 11 at age 9, so you can start that early. But we really want to see the whole series finished by the 13th birthday. And so I urge you, instead of thinking about 13 to 26 for girls and 13 to 21 for boys being catch-up, but to think about that as vaccines that are late and overdue. So our call to action to you is that when you're having a conversation with parents about HPV vaccine, give a strong recommendation to all parents of girls and boys that are 11 and 12 years old. Also, I know you guys are all pediatricians, but I also encourage you to talk to your clinician friends, and if they're family practice docs, they can use cervical cancer screening, or if they're OB-GYNs, to talk to moms about HPV vaccination for their kids. Moms really trust the clinicians who are doing their pap testing. And also, we want to make sure that at all points we are reinforcing the message that HPV vaccination is about cancer prevention for both girls and boys. So now I'm going to get into the nitty-gritty of the questions that parents ask. So what do you say to parents who resist or bring up safety concerns? And one thing that we commonly hear is parents saying, oh, I only want the vaccines that are required for school. And I recently just met a physician in Indiana who had a great response, which is, all 3 of these vaccines are equally and strongly recommended by the CDC, by pediatric, adolescent, and family physician groups. School entry requirements don't always reflect the most current medical recommendation for your child's health. I am here to keep your child healthy, and I recommend that your child receive these 3 vaccines today. A lot of parents are going to bring up safety concerns, and it's important that parents remember that everything we do in life, whether it's if our kids are playing soccer, if they're taking acetaminophen, if they're riding and or driving a car, if they're mowing the lawn, all of those things have risk associated with them. Getting out of bed in the morning has a risk associated with it. But vaccinating against HPV cancers is much safer than making the decision not to vaccinate. For parents who are struggling with the fact that their child may not be sexually active anytime soon or may not be exposed to HPV infection, we want to help them understand that we don't try to guess when exposure will occur. And so most parents are familiar with, and hopefully are endorsing, the use of bicycle helmets. You could also use seat belts as an example. And so you ask them, when do you want your child to put on their seat belt, or when do you want your child to put on their bike helmet? And so you ask them, do you want them to put this on before they get on their bike, while they're already riding their bike, or after they've been hit by a car? And most parents understand that. Now, not all parents are going to say yes. As I said before, just giving that bundled recommendation can get about 70% of parents to yes, but that leaves a big chunk, about 30% of parents, who may not say yes right away. So if a parent doesn't say yes to HPV vaccination, we want to make sure that we're clarifying exactly what their concerns are. So let's go with the ask, acknowledge, and advise here, which is, restate their concerns to make sure you understand. Acknowledge that you want to keep their child safe and healthy in every way. They want to do that. You want to do that as well. This isn't just about public health safety. For instance, that's a good or when parents say, I just want to get the vaccines that are recommended for school, that's about public health and safety in general, but you're there caring for their child, and that's why you recommend these vaccines. And then also advising, make sure that you're answering the question they care about, give them time to talk about the pros and cons. If it's a really specific safety concern, say, can you tell me where you saw that, or what you've heard, or can you show me on your phone what you saw on Facebook that's concerning you? So you're going to have some patients whose parents are going to give them other vaccines. They're just concerned about HPV vaccines. And so for that parent, instead of saying, immediately starting with, say, the safety study data and things like that, instead we encourage you to say, it sounds like generally you're in support of vaccines, but you have some concerns about the safety of HPV vaccine. Is that correct? And then if they say yes, so if you had some information that convinced you HPV vaccine was safe, would you consider letting your son or daughter have it? And it's almost always daughter, by the way. Most parents have safety concerns. It is safety concerns about their daughter getting the vaccine. We very rarely see parents with safety concerns about their sons. And so you could say, you know, I'd like to share with you what I know about the safety of this vaccine. And what you might find out in that conversation, it's actually really not about safety, that it's about them being concerned that their child is going to have a green light to go have sex or something like that. And so this kind of conversation can help you come to yes, and it can also help you understand what the various nuances are in terms of what mom is concerned about. We also encourage you that if a parent does decline on that particular day, that declination is not final forever. That, you know, we encourage you to revisit this conversation. Make sure that you leave the door open, that you can, you know, say, okay, well, this is something I want to continue to discuss with you. Is there information I can send you home with today? And we can discuss it again next year. Or if it's before flu season, you know, when you bring your child back in for their flu shot, I'd really like to talk with you more, see if I can answer some of your questions. And you can choose whether or not you would like the parents to sign a declination form. A lot of practices have been working on things, whether it's with one of the pharmaceutical companies or with their local AAP chapter, but quality improvement. And there are some simple office changes that they've made in order to increase HPV vaccination uptake. So one of the first things that we recommend is that everyone in the office or clinic or practice be saying the same thing. So that includes people who are answering the phone, making appointments. We want to make sure everyone's communicating about HPV in the same way. And to give a good example, we had someone here in our office who actually called to get her daughter vaccine and was told by the receptionist, well, we don't give that vaccine until they're 13. Which actually wasn't the office policy. Obviously that person either was confused or had their own hang-ups about HPV vaccine, but you want to make sure that everyone understands why this is so important. So put the focus on cancer prevention, provide talking points for the staff. One really good option for this is this addressing parents' top questions about HPV vaccine. We used to call this tips and time savers. So not only does it explain how to give the recommendation, but it also gives a number of different answers for questions. And you can use this as a simple in-service with your staff to make sure that everyone is on the same page. Now there's another thing that some clinics have been trying, that when the nurse or the MA is doing vitals and asking questions, that they can also say, so also by the way, now that your child's 12, there are 3 vaccines they'll need today. They're designed to protect them from the cancers that are caused by HPV, as well as protect them from meningitis, tetanus, diphtheria, and pertussis. Do you have any questions for me? And this would actually be done by the nurse or the MA as the opener. If the parent were to express concern, then MA or nurse could say, our practice is so dedicated to cancer prevention that I'm sure the doctor, nurse practitioner, PA, will want to talk with you about your concerns. This is also a great response to a parent that even without the nurse or MA saying anything about vaccines, sometimes a parent will come in and say, look, we're here just for adolescent vaccines today, just the ones that are required for school. And that it's a good opportunity for the nurse to say, you know what, our clinicians feel really strongly about HPV vaccine for cancer prevention, so I know they're going to want to talk to you about that. And it just leaves that door open to have a continuing conversation. So there's also been some really interesting research coming out lately about reminder and recall and whose job it is to be responsible for knowing there are other doses in the series or when someone needs to come back. Our research has shown that most parents have no idea how many HPV vaccine doses there are in a series and when their child needs to come back for those. So even if they know that there's 3 shots in the series, they don't know when to come back. And what's interesting is that some recent research out of Kaiser in California showed that the clinicians tended to think here at Kaiser in California that the parent was responsible for knowing that information, but the parents believed that the doctor's office was going to let them know. And so obviously there's a little bit of a disconnect there. And so I really strongly encourage you, to once a patient has initiated HPV vaccination, you say to mom, you make sure that you bring them back for their next 2 shots. You're going to need to come in about 2 months for dose number 2 and about 6 months from now for dose 3, and be sure to make those appointments before you leave today. And I highly encourage you to be making appointments 6 months out. Even if the parent has to reschedule, it's a good reminder if something's already scheduled and on their calendar. I mentioned someone you love already, and we've mentioned making sure that everybody in the clinic or practice is on the same page in terms of HPV vaccination for cancer prevention. And a good way to let people know why this is so important is you could do a screening of someone you love in your office. In fact, even nurses and pharmacists can now get continuing education credit for watching this. You can watch it online. It can be screened, you could get a site license, you could sponsor screenings, so there's a lot of different ways. And like I said before, if you have not already seen this, I highly recommend it. It's a very moving and excellent documentary. Now, last year when the National Immunization Survey teen data came out, one of the things we saw was that there were 5 jurisdictions, so 4 states and 1 city, that had really large increases in HPV vaccination coverage, so double-digit increases. In fact, across the country, we only saw a 3% increase overall, so we know that those 5 states were really carrying that average for the whole country. And of those, most of them were involved in a special project for improving HPV vaccination coverage. And there were 5 areas that they focused on. And so we can look at those states and say, they were focusing on these 5 areas and we've really seen huge improvements. And so let's talk about these 5 as ways that we can improve HPV vaccination across the board. So one was joint initiatives with cancer prevention and immunization stakeholders. So we encourage you as members of the AAP to get involved in joint initiatives with whether it's sponsored by the immunization program or the cancer program. You can be a champion for HPV vaccination and really help drive increasing rates for your entire state, your local area. Another was comprehensive public communication campaigns. Often these included statements from clinicians. So again, if there is a comprehensive campaign in your area, we encourage you to be supportive of that and possibly, offer to be a champion for their project. We also found that reminder recall in general improves rates, but ones that were based on the immunization information system or even your own patient registry work really well. Also participating in either a quality improvement project or assessment and feedback activity like AFIX. So if you're a Vaccines for Children provider, having an AFIX visit, which you can request, is really helpful. And especially talking with other clinicians on how you can provide an effective recommendation for patients 11 or 12. So if there are other clinicians in your practice who aren't on the webinar today, be sure to talk with them about the importance of giving the bundled recommendation. And then also these practice-focused strategies. So in terms of your key clinical and administrative staff, helping them understand the importance of timely, routine HPV vaccination, so for 11 and 12-year-olds is really important as well. We have a number of different resources to help you here at CDC. This is super easy. I mean, even if you never had the slides, hopefully you can remember. You can just go to cdc.gov and either type cdc.gov/HPV or even just up in the search box at the top of the CDC website, search on HPV. And you would come to this website, which is our portal for all the information that we have on HPV and HPV vaccination. So if you were to click there in the center on for healthcare professionals, you would come to this page, which is our for clinicians page. And so we have it broken down into understanding the facts around disease and vaccination, how you can work on promoting vaccination in your offices or for your area, and then also not only how you can successfully communicate with HPV vaccination with the parents of your preteen patients, but how you can become a champion with your colleagues in your community as well. So we've got a number of free continuing education opportunities, fact sheets designed for you, the clinician, some easy to read schedules. So we know that it's really difficult to read the 4-point font on the back of the immunization schedule. We have some easy to read versions that are especially helpful for parents. Also, you can look at the coverage data for your own states. We have a number of different tools that you can use in your own office or provide to parents, and they are in English and in Spanish. We have a whole section that's just Spanish resources. So if you have a population where the parents are primarily speaking Spanish in the home, these might be great resources for them. And then in terms of being able to answer questions either from parents or when you're speaking to colleagues, we've got information on doing that. We have a great slide set, a You Are the Key slide set that you can use to provide presentations to others. I encourage you to become an HPV vaccination champion in your community. And also, I think more and more pediatric practices are moving towards having actual content, health content on their websites. And CDC provides a service called website syndication. So essentially the content that's on our website about vaccine preventable diseases and the vaccines to prevent those, you can actually take that content and put it on your website without having to copy and paste. So whoever does your website, you can send them to this page that we have on website syndication, and they can actually pull in that content onto your page with a little bit of webmaster finessing. So that as soon as we update our website, you don't have to worry about keeping up with the website all the time. When we update our content, it's automatically updated on your site as well. As I mentioned, we have a number of continuing education, very similar to what I'm doing right now. You could have others in your practice go online. It's a web-on-demand video, so they just download it and watch it and they get the credit. We have a brand new version of this that we just posted last month. This one that we have up right now, we have a number of different continuing education activities that we do with Medscape. This one, unfortunately, is no longer for credit, but it is an excellent, not quite an hour long, I mean, it depends on how fast of a reader you are, but essentially it provides case studies and it's interactive, and you watch the video and hear the clinician make the recommendation with mom, and mom's got a whole lot of really detailed questions because, as you can see, she's a high information seeking mother, high SES, and really wants some good information from the clinician. So really good opportunity there. Another video for training or in-services that you could do in your practice comes from Minnesota. They did a great series of videos, and so I encourage you to take a look at these as well. And then, as I mentioned before, we have a number of fact sheets for parents that are both in English and in Spanish, including our easy-to-read schedule. It's also now in Spanish, and it's in black and white, so really super easy to print and make copies of. And we encourage you to provide these materials to the parents of your patients before the office visit when they are due to receive the adolescent vaccine. So maybe at the 10-year-old visit, you give these out the year before. We also have a number of posters that are available for free that you can order from our website in a number of different sizes. These are really great things to hang up in your office if you do that. So just as a review, we want to remind you making a presumptive bundled recommendation is the most effective recommendation that you can give for HPV vaccine. Also, use the tip sheet that we have, that answering questions or answering parents' common questions, and then all the vaccine resources that we have available. Also, if you want to know when we have new resources and tools, I encourage you to send an email to us to request our newsletter. You just send that to preteenvaccines@cdc.gov. We can also provide speakers if you're looking for speakers for an event, grand rounds, continuing education. We can help provide speakers for that as well. And lastly, I just want to leave you with, preventing cancer by not smoking and wearing sunscreen and eating broccoli requires a lifetime of action. But HPV vaccination is just 3 shots. And we heard this from an oncologist at a cancer prevention meeting, and we thought it was really great. And so I just wanted to leave you with that. And now I can take some questions.
Okay, thank you so much, Jill. So we're going to begin the question and answer session now, and just as a reminder, everybody can answer questions into the control box that's on the right hand side of their screen. So our first question is there any research on post-exposure immunizations that immunize patients from cancer?
Yeah, so actually there are a couple of studies through NIH right now looking at whether or not HPV vaccination has an impact on the cancers once someone's already been exposed. So if they, does it decrease the risk of cancer? Does it, do we see less lesions, that kind of thing? The most important thing is that we never know exactly what someone's been exposed to. And so even if someone has already become sexually active, or we know that they've been exposed because they've had either genital warts or a positive HPV test or an abnormal PAP, it's still important to vaccinate them, because especially with Gardasil 9, the 9-valent vaccine, there's so many different types included in it now. Chances are they don't have all of them. They maybe only have one, especially if they are just if they just have a genital warts diagnosis, they may not yet have been exposed to HPV 16 or 18 or one of the others. So one, we want to make sure we're always vaccinating everyone regardless of their exposure. Two, yes, there is research ongoing about whether or not these vaccines will be useful possibly for treatment and that kind of thing. In terms of post-exposure prophylaxis, jury's still out on that. We don't have any data on it yet.
Okay, and the next question is, have any countries that use HPV vaccine programs been able to eliminate HPV or HPV cancers?
So yeah, we've actually seen some really super promising data out of Australia. And what's neat about Australia is that they got to 80% really fast. And so they have school-based vaccination clinics, and they just were able to get to 80% very quickly. And so we are seeing data out of their country that we didn't expect to see for years because we thought it'd take a much longer period of time. And one of the neatest things that they had was when their program was a girls-only program, so they didn't start vaccinating boys until after 2012. But prior to that, as they were vaccinating young girls, they started seeing just huge decreases in the number of genital warts cases, not only in girls, but also in boys. And I mean, they have some areas in Australia where they had only one case. I mean, so really dramatic. I think in girls it was like a 93% decrease in genital warts cases in teenagers. So really massive decreases. In terms of completely eliminating HPV, there's right now we have a 9-valent vaccine, and there's other types out there as well. And the types that are included in the vaccines are not the most common types of HPV. They're the types that most commonly cause cancer. So we're still going to see HPV circulating, and until we get most countries at the level of herd immunity, we're still going to see the HPV types that cause cancer circulating as well, and it's going to take us a while to get there. But the data out of the countries that got to the levels of herd immunity really quickly are incredibly, incredibly promising and very exciting.
Why isn't the American Cancer Society more active in recommending HPV vaccines?
Yeah, so actually this year, the American Cancer Society actually did come out with not just a statement, but an entire document about it. And they are involved in 2 different projects right now. So about 18 years ago, the American Cancer Society started a project for colorectal cancer screening, and they developed a national roundtable, and it has been incredibly successful. And so 2 years ago, the American Cancer Society started, with funding from the CDC, a national HPV vaccination roundtable. The American Cancer Society feels very, very strongly about HPV vaccination, and I think they, like many of us, just expected HPV vaccination to go the same way that Tdap and meninge did. We introduce a vaccine, within the first 5 to 8 years, we see 80%. I don't think any of us have to see the big difference, the big gap between the other adolescent vaccines and the rates for HPV vaccination. So the American Cancer Society has become very involved in it. They have 2 separate projects, as I mentioned, the National Roundtable, and then within that they're also working with states to develop state-level roundtables. And then secondly, they have a project working with federally qualified health centers. So the American Cancer Society has liaisons at about a little more than half of the federally qualified health centers in the country, and they are doing a large HPV vaccination project. And I think we'll start to hear more and more about that as that gets out. But yes, they are actually very active in that, and hopefully will continue to stay active even once the funding's not available any longer. And if you haven't yet, I do encourage you to get in touch with your local American Cancer Society representatives and chapter.
Okay, next question is, how many years out do we have data for the HPV immunity due to the vaccine?
Oh yeah, so actually there's going to be some data that comes out about that at this next ACIP meeting in just a couple of weeks. But right now, we have the 10 years that the vaccine has been out in the market, plus the years that it was in the clinical trials. And so if we just look at, say, the 10 years of data, we can see that there's very, very little waning immunity and nothing like the drop-offs that we've seen with Tdap or meningococcal vaccines. So the 10 years of data that we do have are demonstrating very, very high efficacy, very little waning protection, which leads us to believe that we're not going to see any kind of drop-off anytime soon.
Okay, do you recommend one booster of Gardasil 9 if our patients received 3 Gardasil quadrivalent?
Sure. So currently there's no recommendation to receive additional doses of HPV-9 after receiving a full series of quadrivalent or bivalent vaccine. We don't know what the efficacy of just one dose would provide, and there's no recommendation to quote-unquote revaccinate someone with a full series. What's good to know is that the majority of HPV cancers are caused by HPV-16, which is included in all of the currently available vaccines, and that is closely followed up by HPV-18, which is included in all of them as well. So we get about 65% protection with just having 16 and 18 included. And then with the 9-valent vaccine, with the additional types, 5 types, we get about 15% more protection for girls and about 5% more protection for boys.
Okay, so it looks like we do not have any more additional questions. So I'm just going to go ahead and wrap up the webinar. Jill, is there any other last remarks you?
I was just going to say, if there are any additional questions, if something comes up in the next couple of days, something percolates, please don't hesitate to send it in, and Anne will send them to me, and we'll get your questions answered.
Yes, definitely. Oh, looks like I do have one more question real quick.
Sure.
Let's get that one in. So do you see schools making the HPV vaccine mandatory in the future?
No, actually, we don't really see that that happening. So what's really interesting is what the current data shows us is that states that have a Tdap mandate have higher HPV vaccination rates than states that don't have a Tdap mandate. States that have both Tdap and meningococcal conjugate vaccine mandates have even higher rates than the states that don't have also a meningococcal conjugate vaccination mandate. The states that have HPV vaccine mandates actually have lower rates than states that don't. So we have not seen mandating HPV vaccination for school entry to be actually a help to increasing the rates. And there's a lot of different reasons for that. But as we encourage people to become HPV vaccination champions, putting their effort into advocacy to mandate the vaccine is not something we'd recommend. That just the return on investment has not been seen. And I know that's difficult because there are so many parents who equate school requirement with the most important vaccines, but there's a number of other childhood vaccines that are not required for school entry that parents get very willingly. So I think as we educate more parents on the importance for cancer prevention and that this is just a normal part of adolescent immunization and that it's for their personal child's health, not thinking about public health, across the board, that really helps.
Okay, awesome. So thank you so much again, Jill, for the presentation. I'm just going to quickly wrap everything up then. So I wanted to remind everyone that you will be receiving a copy of the PowerPoint slides, a link to that should be evaluation, not webinar, and a link to the recording of this webinar by the end of business day. And everyone has to complete the evaluation by June 29th, 2016. That's 2 weeks from today, and after that date, the evaluation will be closed and you will no longer be allowed to fill out the evaluation or receive a certificate of attendance and or continuing education credit. Everyone should be receiving the certificate sometime in mid-July. So that wraps up our HPV webinar. Thank you so much to everyone for attending. Please be sure to check out all of our future webinars that we have coming up later in the year. And once again, thank you to Jill for the wonderful presentation.